Warland. Yo diría de ella que es una de las personas más reconocidas en el ámbito internacional sobre prevención de mortalidad perinatal. Tiene muchísimas publicaciones al respecto, que ha presentado en congresos internacionales, y le damos mucho las gracias por venir. Ella es matrona con larga experiencia, investigadora y profesora en la universidad. Así que, thank you, Jane. Adelante.
I don't understand Spanish, so I hope that was all good. Thank you so much for inviting me to speak to you today. I'll go as slowly as I can. Today I wanted to talk to you about risk factors for fetal death that we know about, and some of the exciting research that is happening in the world for where we are going to build on what we already know. I thought I'd start by showing you my family. I have 4 adult children, and their partners are also seen in this photo, and my 4 grandchildren. The person missing from this photo is our daughter Emma, who was stillborn 31 years ago. The other picture is of Adelaide. Adelaide is a very picturesque city in South Australia. It's not as big as Melbourne or Sydney, but people who live in Adelaide, I think, are a little bit like people who live in Santander. It's a very nice place to live. I want to talk about known causes and risk factors for stillbirth, and the ways that maternity care providers can raise and discuss risk reduction strategies with pregnant women. And I see some of the midwives that I met yesterday in the audience, and thank you for coming back to listen to me. I also want to talk about risk factors for stillbirth that might be modifiable or able to be changed, and that might help us identify when the baby is compromised. I'm going to quickly show you this picture just to show you that in Australia and in Spain we have very similar mortality rate for stillbirth. This slide you might have seen before, perhaps Alex Heasel has shown it to you. The arrow shows you Spain's level of stillbirth post 28 weeks, and in 2016, which is the date of this study, the rate in Spain was 2.9 per 1,000 babies born after 28 weeks. And by comparison, Australia, which is slightly lower on this scale, so slightly better, had a stillbirth rate of 2.7 per 1,000. And our latest data in Australia from 2021 was 2.4 per 1,000. So that tells you that in most high-income countries across the world, there is ever so slightly reduction in stillbirth rates happening, just because we are better at detecting things like fetal growth restriction, and of informing mothers also about things that they need to look out for to help protect their baby. This is also a slightly old slide, but things haven't changed much since 2013. So we still know that parity of the woman having her first baby, hasn't ever been pregnant before, or having greater than her third baby are at increased risk of stillbirth. We don't really understand the mechanism for that. Also, ethnicity of the parents, whether they are from Africa or South Asia. In Australia, women from South Asia are a significantly increased risk. Maternal obesity is also, or overweight, is also a risk factor, as is smoking and diabetes. All those sort of things that we've known about for quite some time are risk factors. The problem with all of these risk factors, really, apart from perhaps smoking, is that you can't do anything about it. You can't say, well, I actually would prefer that you're having your second baby than your first baby. I would prefer that you had lost a lot of weight before you became pregnant when she is already pregnant. So there's a lot of these risk factors actually aren't things that can be changed, especially once she's pregnant. I also wanted to show you this slide because it's divided into under 28 weeks and over 28 weeks and the causes of stillbirth for those gestations. And you can quite clearly see that congenital abnormality is fairly consistently an increased risk for both of those gestations, meaning that it's a risk throughout pregnancy. However, if you look down to the third from bottom, you see unexplained antepartum fetal death. And that changes significantly from the early gestations to the later gestations, such that if you are over 36 weeks and you have a stillbirth, it's likely that about 30% of those will be unexplained. So the factors that the mother might be able to modify herself with information from her care provider is to get to know the baby's normal, the strength, frequency and pattern of the baby's movements, to trust instincts and report concerns, and to settle to sleep on the side. So these are the three very key messages that we have identified, at least in Australia, as being important for the woman to be aware of. So getting to know the baby's normal, looking at frequency, strength and pattern, we've known for a long time that if the baby moves less, that puts them at increased risk. But now we know from these studies that you see on the slide that if the baby moves less strongly or changes their pattern, that also puts them at increased risk. So the studies were conducted in England, online, in Australia, the Sydney stillbirth study, the Auckland stillbirth study, and then all of those collaborators got together and looked at a individual patient data analysis for all of those studies combined, and you see on the table the key findings from this. So I'll just talk you through it. It's likely to be protective if the baby is moving vigorously and the mother says words in English like, the baby's very busy, the baby's very active, the movements are very powerful. These are all quite logical, I think, things that are likely to be protective if you're thinking about the strength of the baby's movements. Also, the mother is likely to say that there is increased strength and frequency. So not only the number of times the baby moves, but the fact that the baby is getting stronger and stronger. A typical diurnal pattern, or one that changes or doesn't change actually over the course of the day. So you either have a baby who is active in the morning and not so much in the evening, or you have a night owl baby who's very active in the evening and not so much in the morning. So women can typically pick that diurnal pattern of movement from about 28 weeks. And the last thing is occasional hiccups. So we all occasionally hiccup. It's a physiological response. But what we have found from these studies is if the mother reports endless hiccuping, where the baby actually isn't really stopping much, it's just hiccuping endlessly, that means that the baby is at increased risk. We don't really understand why, but I guess just if an adult came to you unable to stop hiccuping, often we will hospitalise that adult to figure out what's going on, because it's not normal to be endlessly hiccuping. One of the things about pattern and what we mean by pattern isn't well understood yet, I think, by a lot of women and perhaps a lot of care providers. So I've invented this acronym, which probably doesn't work entirely in Spanish, but it's talking about the typical fetal response to the acronym TIME. So T in this stands for time of day, and this doesn't mean that, you know, the baby will always move at exactly 11 o'clock. It means that the baby is typically a morning person or typically an evening person. Internal stimulus can be from the mother suddenly bending over or scrunching down. The baby will often move to that internal stimulus because they feel cramped. The maternal activity and or rest, so often if the mother is getting ready for bed or even lying in bed ready to go to sleep, this will be when her baby starts becoming active. So it's a response to her resting and the baby becoming active. And the final one, an environmental stimulus such as hearing a very loud noise. Some babies will jump. Familiar voices, so the voices of the baby's siblings or the baby's father or partner. And a tummy touch, so the baby actually recognising the touch from a family member, and either being active to that touch or being quiet to that touch. So some sort of pattern that the mother can recognise around that acronym TIME. The other thing I wanted to talk to you about was myths and perhaps busting some of those myths. So midwives and other care providers need to know that there are a lot of myths that can actually put the pregnancy in danger because it's not necessarily true. So the first of these is that it's normal to feel less movement towards the pregnancy, towards the end of the pregnancy as the baby runs out of space. You've heard that? So that is actually not true. The baby should be getting stronger and stronger towards the end of pregnancy. And if the baby moves less, that may indicate that the baby's in trouble. So we need to be very mindful of the woman who comes in and says, oh, my baby's moving less, but my mum said that that's because he's running out of space. Our role then is to say, actually, that's not true. Let me start to assess what might be happening with your baby. So we have some research which supports that, and I guess the most recent one is from Billy Bradford in 2019. She did a very nice study looking at differences over the course of pregnancy, late pregnancy, and fetal movement change. So the next one is women who experience altered fetal activity. That's what that stands for. Should be told to sit down and drink a cold or sweet drink before presenting to hospital. And again, this is very common. It's something that women will tell each other. Oh, you're worried about your baby's movements? Have some ice cream. Or you're worried about your baby's movements? Have some orange juice. It actually doesn't make physiological sense that having a cold drink would make the baby move, because the stomach is a long way from the uterus and the baby is surrounded in the uterus by fluid at body temperature. So if the mother eats something cold or drinks something cold and it goes into the stomach, there really isn't a physiological way for that coldness to be impacting on the baby. The key thing about this is that some people, when I say that, still don't believe me, and they say, but it works. It might. So if you drink something cold and the baby does happen to move, what that means is that the baby has happened to move. The thing that it doesn't mean is that cold drink has made the baby well. So we need to be very mindful that if the mother says, oh, I drank some orange juice and the baby moved, so that means everything's okay. No, it doesn't. It means that the cold drink or the sweet drink happened to be associated with the fetal movement, and that it hasn't made the baby well, the baby still needs to be assessed. And we have some evidence, again, from research, which shows that if you're eating or drinking something cold, even if you do a glucose infusion, it doesn't wake the baby. So a really common myth that's held by just about everybody, care providers and women alike, is that the well baby moves 10 times in a period of time. As far as I can work out, this myth has come from a study which was actually published quite some time ago in 1989. And what they did was that they got a cohort of women to say how long it took them to appreciate 10 movements, how long that took. And this thing that you see boxed in red is the findings. So the mean time for the mother to think, yes, my baby's moved 10 times, was close on 21 minutes, with one standard deviation being 18.1 minutes. So the vast majority of babies will move 10 times in half an hour. So if you have a woman saying, oh, my baby's fine because he or she has moved 10 times today, then that is cause for concern, because that's way underneath 10 times in 30 minutes. So again, we need to be careful that when women say this kind of thing to us, or you hear perhaps one of your colleagues say it to another colleague, oh, it's fine, that baby's moved 10 times in 2 hours. That 10 times in 2 hours was actually an alarm limit for this study, meaning that if the baby moved as little as that, the participants were instructed to go to be assessed. So somehow this study has become a study which people want to be able to use to say that the baby moves 10 times in a period of time, but that's actually not what the study shows. The other thing about this is that I will regularly give lectures like this, and most recently I had an audience of 71 people, and I asked them the question, well, fetus will move how many times? And you can see from this slide that the vast majority of them said correctly that it varies from baby to baby. So 70%, that's good, very good. However, you can see that 14% of this population still believed that it was 10 times in 2 hours. So we still have work to do across the world with care providers understanding that a well baby will move however a well baby normally moves for that mother. Talking about myths that might have an element of truth, I was talking to Emma and her family last night, and we were talking about how many people have been eaten by sharks and how many people have been bitten by snakes and spiders. And that kangaroos might hop down the streets in Australia. So yes, kangaroos do sometimes hop down the streets in Australia, but it's rare. It's by no means a daily event. To see a kangaroo, you really need to be driving in the country, and we actually have these signs. A kangaroo and a cow, watch out for both of them. And if you want to see a kangaroo, you go to a wildlife park. So this is one of my granddaughters feeding a kangaroo in a wildlife park. So myths that have an element of truth for people who are looking after pregnant women tends to be around this idea that a woman with an anterior placenta can be reassured if she presents with reduced fetal movements because the anterior placenta is muffling the movements. Now that's sort of true, but not entirely, because the anterior placenta is anterior for the whole of the pregnancy. It doesn't suddenly change, and with that change, if the mother notices the baby is moving less, it can't be because of the anterior placenta. So the woman with an anterior placenta will get used to having that sense of her movements being perhaps a little bit more muffled than before. If she's had a baby before, she might tell you the movements feel different. They feel more internal to me than external. So an anterior placenta can impact on movement, but it shouldn't be a reason why you would reassure a woman who is expressing concern, because the anterior placenta isn't new. So if the concern is new, then that's a reason for you to investigate what's happening. So that's busted too. I want to move on to interesting research that we did a little while ago now, where we reported a woman with a gut instinct that something was wrong, was at increased risk of stillbirth. So here's the study, and we called it "They Told Me All Mothers Have Worries," because often when a mother says to her care provider, if she's brave enough to say it, I'm concerned about my baby, I just have this feeling that something's wrong, the care provider will often respond to her by saying, don't worry, it's natural to be anxious during pregnancy, and they'll dismiss her concerns. What we found was that the risk of stillbirth in this case control study was 22.5-fold higher with those who went on to have a stillbirth as a result of having this gut instinct than those who didn't experience this. Doesn't mean that you can't have a stillbirth if you feel everything is okay. Doesn't work like that. But certainly if the care provider hears the mother say, oh, I just have concerns about this baby, can't put my finger on it, really not quite sure how to even describe it, but I'm concerned. So if you read that study, you'll see 4 themes that we identified for that study when the gut feeling occurred, and that was typically from the very beginning of the pregnancy. And if you had experienced a pregnancy before, it concerned you because it was new for this pregnancy. There were also women who talked about having dreams and other premonition kind of phenomena, and sadly that they were often reassured by someone or something. So the someone could be a partner or a mother or a care provider saying, don't worry, it's natural to be anxious, and something, the baby might be nicely active, so you're actually thinking, oh, there's something wrong, but my baby's moving fine. So there can be this disconnect between what the mother is feeling and her natural maternal instinct. Other people have also reported this phenomena. So the Swedish group that some of you may know, led by Ingela Rasdad, has conducted a couple of studies in this area showing that women can have a gut instinct that all is not well with the pregnancy. And we even see it amongst SIDS parents, the sudden infant death parents. They have reported having a premonition days before their baby's death. Unfortunately, because it's a little bit psychic and a little bit women with concerns can delay reporting this particular concern. So it might pay for us as care providers to actually say, do you feel like everything's okay? Tell me about if there's anything that is concerning you. So the going to sleep position is something that is really coming into our way of managing pregnancy and information that we give to parents, particularly in Australia. It'll be interesting to hear what's happening here in Spain. But basically there were a number of case control studies mainly that all showed that if the woman goes to sleep on her side, that she's at less risk of stillbirth than if she should settle on her back. And now we actually have evidence from a large individual patient analysis where all of the data from all of these studies was pooled, so that there were 851 cases and over 2,000 controls. And that showed quite conclusively that if a woman goes to sleep on her back compared to any other position, left side or right side, that she has a little bit over 2.5 times increased risk of stillbirth. And excitingly, and I think quite relevant, is that just this on its own, if every woman started doing this at 28 weeks, lying down to sleep on her side instead of on her back, we could potentially save nearly 6% of stillbirths that are currently happening. To put that into perspective, in a meta-analysis for smoking during pregnancy, similar kind of thing where they used lots of people who had said that they were smoking and lots who weren't, the risk of stillbirth in the group who smoked was only 1.5, versus if we go back to this, it's 2.5. So we have a big opportunity to make a big difference very easily with this group. Strategies that you can know about so that you can tell your women is a very popular use of pillows behind your back, under your bump, between your knees is typically where women will put a pillow to comfortably sleep. If they have long hair, if they put that hair in a low bun at the neckline, that can help the woman not to be sleeping flat on her back because it's uncomfortable. We came up with this technique of a tennis ball in a scrunchie at the centre of the back, so just tying a tennis ball with a hair tie around it and positioning it directly on your back. And then I'll talk about this a little bit more detail a little bit later, but I've been working with a group out of Canada for the last 10 years, and we have developed a wearable device, which means that it doesn't really matter what the mother does. She can't kick this device out of the bed so it lands up on the floor. She can't move it away from her body as she sleeps because it's attached to her. So we in this group think that this is an important way forward, that women are encouraged, if they're very concerned about constantly waking up on their back, that this device actually prevents that from happening at all. So things a maternity care provider can actually do is that we need to be encouraged to talk to women, to give them the evidence-based risk information throughout pregnancy. And I'll talk a little bit about why we might be concerned about doing that. Believe her when she reports concerns and thoroughly investigate her when she comes in with concerns. So in Australia, we have recently worked with the Australian Commission on Safety and Quality in Healthcare, bit of a mouthful, to create a stillbirth clinical care standard. Now this standard guides care. It's not a policy, it's not mandated, it's a standard that we put together to try and guide clinicians into what's good practice around stillbirth and stillbirth prevention. So there's 10 statements around risk assessment before and during pregnancy, stillbirth awareness and strategies to reduce risk, who needs to know and what we need to tell them. Ultrasound during pregnancy, so if the woman reports concern, what the ultrasound can actually tell us. Changes in fetal movements, really very key to it all. Timing of birth, little bit contentious for some of us, but in Australia we're tending to move towards trying not to induce the baby until the mother is at least 39 weeks. Stillbirth investigations, once a stillbirth occurs, how do we routinely collect information which we can then compare across different cohorts to try and find out what happened? Reporting and documenting. We have, as I mentioned, a 2-year delay in the statistics happening, the stillbirth happening, and us getting the statistics around it. That's way too long. We have really no idea. We're completely blind as to what happened last year and the year before at the moment. So we are trying to address that. Bereavement care and support, obviously very key and very important, and subsequent pregnancy care, because the woman is at increased risk of another stillbirth in a subsequent pregnancy. I wanted to highlight Quality Statement 5, which is a change in fetal movements, because now we have, for the first time in Australia, a document which talks about not only a decrease in frequency of fetal movements, but also a change in strength and a change in pattern, as all being really very crucial. Billy Bradford put together a framework for conversations about fetal movements that we recently published in Women and Birth. And again, this is about encouraging women to know what to expect regarding fetal movement, the strength of the baby's movements, the frequency and the pattern, and when they should seek assessment, and how we can actually do our part in having that conversation. So what do? We've put together this ask, listen and inform thing. So the first thing is ask. A lot of people will ask women about fetal movements by saying, is your baby moving? And the problem with that question is that the woman can answer yes until the woman answers no. So is your baby moving gives you very limited information about the baby's well-being, how the mother is getting to know her baby, if the mother is even noticing what the baby is doing. So an open-ended question, in English, tell me about your baby's movements, is much better, because then you actually empower the woman to tell you about what she knows, who her baby is, how her baby is, and she then knows to report any concerning changes in fetal behaviour to you. And it encourages you as the maternity care provider to listen for those key strength, frequency and pattern. Now, I'm going to give you an example. Normally I have people read this with me, but I'll do my best at reading it and explaining as I go along. So the woman might say to you, my baby is moving all the time. When you say, tell me about your baby's movements, she might say, my baby's moving all the time. So that gives you frequency, yes, but it doesn't give you strength or pattern. So as a care provider, you want to know about strength and pattern, so you ask her. That's great, you tell her. Tell me about the strength of your baby's movements. So then she might say, yes, sometimes he feels like he's going to jump out of my belly. Even my husband can see my baby moving. That's good strength, right? So the care provider can respond, wonderful, that she's growing so strong. Can you tell me more about pattern, because you've got strength and frequency now, but you still haven't heard anything about the pattern. Is she a morning person? Is she an evening person? Does she move when she hears a loud sound? What kind of pattern have you noticed about your baby's movements? So the woman says she always kicks when she hears her dad's voice, and she's an evening person. She kicks a lot when I'm getting ready to go to bed. So now you have the whole story. You have strength, frequency and pattern, and by all accounts you can probably tick off that baby is well. Fetal movements are being felt regularly and strongly, and often to a pattern. So moving to this, we talked a lot about this yesterday, do we give this information? Does it actually help to modify risk and reduce the rate of stillbirth? So excitingly, in New Zealand, when Thomasina Stacey published her first paper in 2010-11 about going side to sleep, they noticed the very next year that there was a huge drop in the stillbirth rate in New Zealand, which really could only be attributed to the thing that changed in New Zealand that year, and that was that midwives were saying best to go to sleep on your side. Similarly, in Scotland, they decided that they would have a mandated conversation about fetal movements in the middle of pregnancy. So every pregnant woman had a talk to their care provider about about fetal movements in pregnancy, and you can see again there was a significant drop in their stillbirth rate, and it's still going down. So does talking to women about stillbirth make them anxious? Again, my gorgeous grandchild. One of my honours students did a study. She was a psychology honours student, and the study was that she was looking at messaging and anxiety. So exactly what a lot of care providers are actually concerned about. So she proposed this little vignette, this scenario, that Jenny is in the last 3 months of her first pregnancy, and she hears the sleep on the side message, and she hears that it's to go to sleep on her side to protect her unborn baby from stillbirth. The blue lines are what our participants thought that Jenny might feel when she heard that message. So you can see that the vast majority of our participants said that she would probably feel concerned, or worried, or anxious. So all of those things that we worry about, the friend of Jenny would also be worried about it. Interestingly though, when we said, now how would you feel if you were Jenny receiving this information, and it changed dramatically to informed. So that tells us that we can give information, provided we do it carefully. We don't say things like, if you don't sleep on your side, your baby will die, because that would be silly. But if we carefully give information, evidence-based information, that the woman is most likely to feel informed over concerned and anxious. Yes, she may still be concerned and anxious, but here's the thing. We give health information that can make you anxious to women and men all the time. So if a woman is at increased risk of breast cancer, for example, we'll tell her to follow a certain line of behaviour, having regular mammograms, checking herself, checking with her family, finding out about her family history. All of those things are important to protect yourself. What we don't do is say, well, telling people about breast cancer is going to make them anxious, so we won't talk about it at all. So we need to be taking that same approach with telling women about risk for stillbirth, so that she can actually come to protect her baby. If she has no information, then she doesn't have a chance of protecting her baby. We know from the Affirm trial, the big trial that happened in the UK a few years back, where they looked at giving information to women during pregnancy about fetal movements, and they found a non-statistically significant reduction in stillbirth. It's hard to say that 9% reduction in stillbirth is non-significant, but it's not statistically significant in that study. And they found a higher frequency of caesarean section and intervention like induction of labour. Now again, the thing here is that if you've saved 9% of babies, and you've informed women to be mindful of changes in fetal activity and reporting to care, of course you're going to increase your caesarean rate and your induction of labour rate, because nobody is then going to go, oh, don't worry about that, we're just not going to do anything, we don't want to intervene, we just want to know that you're concerned, right? So of course, if we inform people about what to do if there are concerns, you will increase your caesarean section rate and your induction of labour rate. And the UK Saving Babies' Lives Baby Bundle also found a similar thing. They had quite dramatic reduction in stillbirth in hospitals that adopted that program, and along with it they had a higher frequency of induction of labour and emergency caesarean section. Naturally, of course. If you're raising awareness, you are of course going to raise intervention to save the baby. The other thing that we need to be thinking about is when we have a conversation with women, we do talk to them about death. We talk to them about pertussis, whooping cough information, and the fact that a young baby with whooping cough is really very distressed and sometimes they die. Risk of uterine rupture during a vaginal birth after caesarean attempt, same thing. We talk about that, and we can actually scare women by talking about that. Avoiding foods which may increase the risk of listeriosis, so that's cold meats and cheeses and things. Avoiding alcohol. Many women announce that they are pregnant by avoiding alcohol, so it's a thing that many women know all about. And avoiding smoking, we talk about that too. But for some reason we don't always talk about stillbirth, and I'm advocating for the fact that we probably should. So if you're not already, you probably need to start asking fetal movements using open-ended questions and then listening for strength, pattern and frequency. Encouraging her to go to sleep on her side from 28 weeks and provide her with some strategies for comfortable side sleep. Empower her to know who her baby is and how her baby is, and to trust those maternal intuition feelings so that she can immediately report change. Provide her with information to empower her to advocate for her unborn baby. Evidence-based information. Give it to her. Don't hold it back because you're scared. I wanted to just finish with some of the research that's I'm involved with that's happening in the world that I thought that you might be interested in learning about. The first of all of these we've called the family study, and we read a paper out of the University of Utah a couple of years ago, 18 months ago, which suggested that people carried a genetic link to stillbirth in their family tree. So this is University of Utah, Mormons, they've got family trees going back generations. And they looked at stillbirth and reported that men, brothers, tended to have stillbirths through the family tree, and that women or sisters tended not to. And this is a tendency, and of course there's always reasons why a miscarriage or stillbirth might happen that's not related to genetic reasons. But there was this quite strong association between men and brothers all having stillbirths or miscarriages. So this family in Australia had 3 brothers and 3 sisters, and the brothers had all had miscarriages and stillbirths, more than you would think was only by chance. And the women in the family, the sisters, hadn't had a loss. So we've recruited this family to do whole genome sequencing, including on the stillborn infant, and we're hoping that we might be able to identify a gene a gene that might be responsible for increasing pregnancy risk. Now we think that it might work similar to the gene for breast cancer, if you have this gene, it doesn't mean that you'll get breast cancer, and if you don't have this gene, it doesn't mean that you won't. But we believe that it will work in a similar way if we find it, that the gene, we might find a gene that's responsible for increasing risk. The other study that is currently in press at last is developing an interview schedule with bereaved parents. So we used a modified Delphi approach. If you know that approach, you just consistently ask your panellists the same kind of questions until you drill down to the answer that you want. We had 200 participants from across the globe, and we now have an interview schedule which, as I said, we're about to publish, which is asking consistent questions about the experience of pregnancy. Did you have that gut feeling that something wasn't right? Antenatal care, what did your care provider do when you reported or didn't you? Fetal well-being, what happened with the baby's movements, anything that you noticed there. Maternal well-being, how did you feel within yourself when you were pregnant? What happened in the days prior to the stillbirth, and perceived causes of death. So that's quite exciting, and Alex Hizzle from University of Manchester is going to take that and use it and see what we find. We know that the current pregnancy pillows that are on the market are for comfort, not to keep women off their back. And the reason why we know that is that over 10 years, as I said, we've been developing this pregnancy pillow that actually is wearable. So it's just on a strap that's around the woman's body, and then when she goes to bed, she can be assured that it doesn't matter what position she ends up in, sideways, upside down, whatever, that the pillow will go with her because she's wearing it. And people who are particularly concerned, I guess, about waking up on their back all the time, this is a device which might be helpful for them. And finally, Alex probably talked about his MyNest study when he was here. It's revealed a lot of actionable factors that have been taken up across the world. Very exciting stuff. But he only looked at 28 plus weeks. He's now sort of extending the study to look at pregnancies between 20 and 28 weeks to try and find new and novel risk factors for stillbirth. So that's pretty exciting. It's going to be recruiting until next year. Thank you for your attention, and do you have any questions?
Okay. Thank you very much, Jane, for your nice presentation. And I wonder if there is questions in the floor. Is there any question? Yeah.
Hi, Jane. Emma wants to know whether the health professionals these days in Australia, they actually inform the pregnant women about the risk factors for stillbirth.
That's a work in progress. So many do now, but we have work to do in that area. Some people still feel like they will be making the woman anxious, and the people who will usually feel like that are obstetricians rather than midwives. So we're doing our best, but it's certainly we have more work to do before that's well covered.
And regarding the myths about fetal movement, is well, so the myths in Australia are well extended, or these days they are more kind of evidence-based information? So are the myths still big thing in Australia? Because in Spain, still the myths are well present. But we don't know if in Australia the information that now is given out is making these myths kind of rule out. And
again, we have. I wouldn't say that nobody believes myths anymore in Australia, but I think we're making good progress in care providers, particularly midwives, understanding that some of those myths are myths, and that has really started with undergraduate education. So when we talk to our student midwives about understanding stillbirth, they get that information so that they know from early on in their practice that there are myths that they need to dispel with their pregnant women.
Right, and you think that the information that the midwives gives to the pregnant women are consistent and is the same along Australia?
Yes, but we've also got the woman might go to her own mother, or she might go to her sister or her aunt, and be given a myth from them. So we can't control all of that other than by giving public awareness. And one of the things that I'm going to be talking about in Madrid is how we have done a public awareness campaign around those kind of issues. So we're going straight to the woman. We don't have to worry about the midwife being afraid to talk to her. If we talk straight to the woman, then she gets the information.
And is the information given like by person, or is printed? Is leaflets?
Printed, social media, television, a variety of different ways of getting in contact with women.
Great, thank you.
Any other question?
I think that gentleman at the back had a...
Oh, sorry.
No, you're right. Oh, good.
Okay. So if not, thank you very much, Jane, for your presentation, nice presentation, and nice results from your experience. Thank you very much.
Thank you.